Fumarate hydratase deficient renal cell carcinoma. Renal cell carcinoma is the sixth most common type of cancer seen in men, typically presenting in the 5th to 7th decade of life. Majority of RCC are due to sporadic mutations, however 4% are associated with hereditary factors. Known risk factors are smoking and obesity, as well as some environmental exposures. So here is a 38-year-old male with past medical history of hypertension who presented to the hospital for 2 weeks of flu-like symptoms associated with nausea, vomiting, and a 20-pound weight loss. Given his presentation, the patient was initially treated for a gastric ulcer, however his symptoms didn't resolve. His labs were significant for transaminitis, elevated total bilirubin, and elevated CA19-9. An MRI of the abdomen was done and showed numerous pulmonary nodules, liver masses, with the largest involving the entire hepatic lobe measuring 24.4 centimeters, and complex cystic masses on the left kidney measuring 6.9 by 6.2 centimeters and 6.1 by 3.9 centimeters. The pathology of the CT-guided liver biopsy revealed metastatic fumarate hydratase deficient renal cell carcinoma. The carcinoma was positive for 2-cystinocysteine and PAX8 and was negative for keratin 7. The carcinoma showed loss of expression of FH, and given the findings seen on the pathology, there was a significant probability that the patient had non-clear cell carcinoma, as the napsin A was positive, and that's typically seen in 70% of papillary RCC and only 10 to 40% of clear cell carcinoma. The bone scan was negative for any osseous metastasis, and MRI brain showed no evidence of any intracranial metastasis. The patient was started on a treatment plan. So the FH gene is a tumor suppressor gene that encodes the enzyme fumarate hydratase, which plays a role in the Krebs cycle and helps respond to nuclear DNA double-strand breaks during DNA synthesis. FH deficiency leads to the accumulation of fumarate, which stabilizes hypoxia-induced factors and promotes tumor development in the skin, uterus, and kidneys. So this condition results in the formation of leiomyomas and RCC, and typically this cancer is rare and it's associated with hereditary leiomyocytosis and renal cell cancer syndrome. So germline mutations of the FH gene are found in 71 to 100% of individuals with a clinical suspicion of HL-RCC, though the actual prevalence is likely higher due to underdiagnosis. This case is particularly interesting given that our patient has no past medical or family history of any diagnosed HL-RCC. His parents are also in their elderly age and well past the 44-year-old range, and they've not been diagnosed with any mutation, which kind of suggests that this is a de novo germline mutation. And on the other hand, they may have the mutation but have incomplete penetrance, which is also known to occur in autosomal dominant conditions. So this highlights the importance of our case, as it not only adds to the limited data on this rare mutation and presentation, but gives family the opportunity for early genetic testing and surveillance to prevent disease progression. So essentially, screening should include staining for FH protein and for cysteination of nuclear and cytoplasmic proteins that are induced once FH function is lost. And once one family member gets diagnosed, it's important for other members to undergo renal surveillance and genetic screening as well, because this cancer typically presents at a later stage with early metastasis.